This is PediaCast.
Welcome to PediaCast, a pediatric podcast for parents. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast. It is a pediatric podcast for moms and dads. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 525 for September 22nd, 2022. We're calling this one Your Child's Skin Part 2. I want to welcome all of you to the program. It is time for another visit from our Pediatrics in Plain Language panel. And that means that Dr. Alex Rakowsky and Dr. Marianne Abrams will be joining us soon. They are primary care pediatricians at Nationwide Children's. And when they visit, we talk about some very basic items that all parents would benefit from knowing regarding the health and well-being of their children. And we strive to do that in a way that maximizes health literacy, so helps you understand, while using terminology that all of us can understand. In other words, this episode will hopefully be free of medical jargon, or at the very least, if we have no other choice than using medical jargon, we'll do our very best to identify it as that and explain exactly what that term means using regular everyday language. That's the goal of these episodes. We don't always meet it, but we try our best to hold each other accountable in that endeavor. Now, you've probably noticed that our episode today is part 2 as we consider your child's skin, which means that there was a part 1 at some point in the past. And this is true. We covered your child's skin part 1 back in May of this year. And the specific topics we covered then included diaper rash, heat rash, baby acne, cradle cap, eczema, or atopic dermatitis, also contact dermatitis, poison ivy, poison oak, and poison sumac, insect bites and stings, tick bites, sunburn, molluscum contagiosum, and warts. And in case any of those topics sound interesting to you, and really they are things that parents ought to know because they're very, very common, I will include a link to that episode in the show notes so that you can find it easily over at PediaCast.org. Just look in the show notes for this episode 525, and you will find a link to Your Child's Skin Part 1. So this week we're going to continue that journey as we explore more skin conditions that are fairly common in kids, including this week Impetigo, Cellulitis, Abscess, Paronychia, Ingrown toenail, head lice, Scabies, Ringworm, Acne, viral exanthems, Chickenpox, and Hives. So, when you consider part 1 and part 2 of this series, there are just so many things that can impact the skin. I don't know. I would say probably more than any other organ in the body. There's just so many things. And so we're going to cover a whole host of them with you today. I do want to remind you before we get our guests settled into the studio that you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for evidence-based child health and parenting information will know what to expect. We're also on social media and love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we also have that handy contact link over at the website, PediaCast.org, if you would like to suggest a future topic for the program. Also, want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you have a concern about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get Dr. Alex Rakowsky and Dr. Marianne Abrams settled into the studio, and then we will be back to talk more about your child's skin. That's coming up right after this. Our Pediatrics and Plain Language panel is in the house once again. You will recall that Dr. Mary Ann Abrams is an assistant professor of pediatrics at the Ohio State University College of Medicine and a pediatrician with primary care pediatrics at Nationwide Children's Hospital. Dr. Alex Rakowsky, also an assistant professor of pediatrics at Ohio State and a pediatrician with Olentangy Primary Care at Nationwide Children's. Let's give a warm welcome back to our friends. Thank you both for visiting with us again.
Thanks, Mike, and happy fall.
Yes.
Hi, Mike, and hi, Alex. It's great to be here today.
Yeah. And, I love when you guys visit the studio because we're not only pediatricians together, I feel like we're also friends, and it's nice to catch up for sure. Mary Ann, we always start with you, and we know that plain language is really a passion of yours. So what is plain language, and why is it so important?
Well, I've got several kind of little tidbits to share today. First, I'll give my kind of common explanation of plain language, which we like to think of it as living room language your grandmother or grandfather or a friend would understand without having to go into a lot of detail. But I also want to say today is September 22nd. We're 8 days away from Health Literacy Month, which is the whole month of October. So happy pre-Health Literacy Month. And in honor of that, I want to make a little pitch to our listeners that if you have a healthcare provider not use plain language with you, you should make sure that you understand. And here are some helpful ways to ask for that, because a lot of times it's hard to ask questions in the healthcare setting. But say, that was kind of complicated. I want to make sure I know what to do when I get home. I want to make sure I've got this right. Can I say it back to you so you can tell me that I've got it right? Or I have to be able to tell the babysitter how to give this medicine tonight, so can I go through that with you? So those are ways, if people are not using plain language, to help get those plain language explanations.
Yeah. And if someone uses a word that they don't understand, it's okay to raise your hand and say, hey, stop. Can you explain what that means?
Absolutely, to do it right then and there. Yeah. But there's sometimes I think giving people the words to use is helpful because it can be scary and intimidating to be in the healthcare setting. And then I just kind of thought this would be fun. As I was kind of preparing for today's sessions, one of the things we're going to be talking about is paronychia, which I'll explain when we get to that. But when I was looking at that topic, I found a couple other words. One is called onychophagia. I think I'm pronouncing that right, which, believe it or not, is the non-plain language way of talking about nail biting. So we can come up with non-plain language terms for all kinds of things. And then the other cute word was punctate leukonychia, which is those little white spots that you get on your fingernails sometimes when you don't know where they came from. Turns out those are from when we kind of bump our fingers hard, or they have just a little bit of trauma that it kind of slows down the growth. So if people want a couple, what do they call it, $1 million words sometimes, $1,000 words, you can go around saying, oh, look at my punctate leukonychia. And you may or may not impress people.
I didn't. If you'd asked me, what does punctate Nichia. Okay. Now, so I can see punctate, small little leuco white, Nichia nail. Okay.
Yep.
Yeah, I probably could have figured it out, but I did not know it off the top of my head. I will say that. What about you, Alex? Did you know that?
I was just thinking about a Paronychia story. One of recent urgent care shifts that I did, we had a young guy that we drained a Paronychia, and I told him, I can't think of an easy word for that. We were just talking about that before the show, and I told him he has a Paronychia. He's like, I have a pair of what? And so
a pair of neck?
I only have one bad thumb. Yeah. So
I mean, paronychia is a word I feel like we use a lot, and you're right. When I say it to parents, their eyes get a little bit wide and what is that? And there isn't really a common term for it.
We were trying to come up with one before this session, and it could probably come out sounding pretty scary. If you've just been told your child has a paronychia, oh my gosh, I thought they just had a little infection. And we'll explain that later in the
if you're wondering what a paronychia is,
stay tuned.
That's right, exactly. We are also loosely following a book called What to Do When Your Child Gets Sick, which is a product of the Institute for Healthcare Advancement. They're a nonprofit organization. It's really a book written in plain language, and it has the very basic stuff that parents really would be helped knowing in regard to their child's health and wellness. Just to improve health literacy, it's really a fantastic book. It's not very expensive to begin with. It's like $12.95. And we have a discount code, POD719, which brings the price down to $7.77. Again, they're nonprofit. We're not getting any kickback. And the book's also available Amazon, Barnes & Noble, and other booksellers. We'll put a link to it in the show notes so you can find that easily. Also, we'd like to hear what you think about these Pediatrics in Plain Language episodes. And we have a survey that you can take. There'll also be a link to that in the show notes. And then don't forget about our playlist on SoundCloud, the Pediatrics in Plain Language playlist. It's all of these episodes kind of bundled together, and we'll put a link to that in the show notes as well. We've really covered lots of basic topics like bedtime and sleep problems, your child's stomach and breathing, and their mouth and their nose, their eyes and their ears, really basic concepts of fever and illness, newborn baby care. So lots of different episodes there for you. And also your child's skin part 1. And then this is going to be part 2. So let's go ahead and start talking about these topics. I had mentioned them in the intro to the show. Alex, you're up first. Tell us about Impetigo.
Another fancy name for a kind of common skin infection. So we're going to be talking about deep skin infections and superficial or top of the skin infections. And impetigo is your classic superficial or top of the skin infection. And the bacteria that give strep throat, group A strep, and another bacteria called staph are the most common causes. And these are like little blister-like lesions that occur in small kids, usually around the nose or the mouth. They can also be found on the hands and the knees or other parts of the body. And it's a mild infection most times. And as the blisters break, they get this like honey-colored crust to them. It can be very easy to get rid of. And a lot of times, like if you see your physician or you see urgent care, they will start just a cream called Bactroban or mupirocin. That usually is a treatment of choice. You occasionally worry if there's some redness extending from these little lesions, or if it starts to get very painful, then you're thinking about this superficial or top of the skin infection kind of diving more deeply inside. And then you need to go of oral antibiotics. And you'll occasionally have oral antibiotics if it's like spread out all over the body.
Yeah.
So fairly common, usually after a scratch. You see it in nose picking, toddlers, and early school age because they'll have some dirt on their fingers and scratch. And these are bacteria that are found in either your throat or on your skin. So they're pretty common just to kind of spread to an opened skin area.
Yeah. And it may be even a little micro abrasion. Mm-hmm. So if you have dry skin.
Micro abrasion?
Is that too much jargon for you? So micro, very, very tiny.
I don't think it's plain language.
Okay, you're probably right. So abrasion is scratch. And so a tiny scratch. A micro abrasion is a tiny scratch.
There you go.
See, it's difficult for us, isn't it?
We have to work at it.
Yes. But if you have dry skin, so like let's say you have eczema in the winter and you have a kid who's just scratching their skin, they can get a little tiny scratch. And then that just the regular skin bacteria that's either on top of the skin or under their nails, right, can take root.
And if you have a child who gets the impetigo often, one trick is just to keep their nails short, wash your hands often. And for kids who are active in the summer, just take a good bath or shower before they go to sleep just to make sure that those microabrasions don't get infected.
Yeah, and keep your fingers out of your nose and your mouth.
Yeah, and things that you worry about if it's really red, really deep, and I'm going to set you up for cellulitis here. But it's essentially if the child gets a fever, we don't see fevers of this usually, but a fever, red, really painful, then you got to get seen because that impetigo has progressed to something more serious.
And one of those things is cellulitis. And so, Marianne, tell us about that condition.
Yeah, I kind of like the way Alex started out. We're kind of going deeper as we go into the skin because I know what he's going to get to talk about next. So the impetigo, we talked about the tiny scratches and maybe you've already got a little rough skin patch. You get the impetigo, those lesions. I don't even like the word lesion. What in the world is a lesion? These little infected areas on the top of the skin. So as you said, if that goes a little deeper through the skin and the top layers of the skin, because we see the outer part of the skin, but there's several layers to the skin itself, which is actually one of the largest organs that we have in our body, the whole skin. So that infection can either start out that way, like say you have a little bit of a deeper cut or something like that, or even a small break in the skin, depending on how much bacteria get in through that, can cause a bigger infection. And when it gets bigger like that, when it gets red, it may feel warm, it may be a little swollen, it might be a little bit tender. You might have some other symptoms that show your body's fighting the infection, but like a fever, just not feeling real well. And even that redness is a sign that your body is fighting the infection, the bacteria that are setting up housekeeping in the skin. That's when we call it cellulitis. And some people, you hear about erysipelas, which is sort of another kind of cellulitis. It kind of depends on what layer of the skin and how defined it is. But that usually is more serious and does need to take, when I say more serious, I mean more serious than maybe just that infection on the top of the skin. And they, as Alex said, they should be seen, and they will probably need to take an antibiotic by mouth. And the antibiotic is usually chosen based on what we learn from the history, any specific exposure, what we know about the kinds of bacteria that are common in our community. And it usually responds nicely to that that oral treatment for a period of time.
Yeah. So impetigo is superficial on the surface of the skin. Cellulitis goes down a little deeper and is more likely to spread sort of horizontally. So the redness spreads. And then if we dive even deeper, now we have what's called an abscess. So tell us about those, Alex.
So an abscess, by definition, is just a collection of pus. So essentially, it's a pus ball. And you can even think of like a zit with pus as a small abscess. I mean, just technically, it's an abscess. And it's usually caused by bacteria, and there are two types of abscess. One involves the skin and its layer, so it can be a deeper collection or towards the top of just a pus collection due to bacteria. And you also have what we call internal abscesses, where somebody can have an abscess in their liver, their heart, their brain, and those are usually very seriously ill children and usually have some reason to kind of get an abscess in a deeper part of the body. You can have an abscess of a muscle, for example, from getting like a puncture wound, let's say.
Or a tooth, right?
Or tooth abscess, yeah. So it's a really broad term, so it's really hard to kind of discuss everything about abscesses, but sticking to the skin here, again, the most common causes are going to be the same two bacteria that cause impetigo, and the two most common causes of a cellulitis. There's going to be group A strep, the strep throat bacteria, and then Staph aureus is the more common one to see of the staph. It can be due to other causes depending where you have it. So if you have an abscess near your buttocks, it could be from flora from your stool. If you have an abscess on the foot, it could be something that you walked over. If you have an abscess, let's say in your armpit, it could be a different bacteria. So there are some parts of the body that may have an abscess due to other reasons.
Yeah. As we're thinking about abscesses, one thing I wanted to bring up, because I think a lot of parents hear this term MRSA. What is MRSA?
Yeah, so again, looking at the two most common bacteria, group A strep and Staph aureus. Staph aureus is a bacteria that lives in our skin naturally. And the vast majority of Staph aureus is classified as MSSA, and it's methicillin susceptible Staph aureus. And methicillin was a drug of choice for literally 50, 60 years against Staph aureus because methicillin is like an older antibiotic that worked great against knocking out infections by the Staph aureus. And then over the years, they started noticing resistant strains, usually in hospitalized patients who got exposed to antibiotics fairly often. And now it's common, almost to the point where, I mean, both of us do either urgent care or ER. You start off with the medicine assuming it's MRSA. And 15 years ago, that was not the case. And when we both trained in the 1800s, that definitely was not the case. You just assumed it's MSSA, unless there was like some risk factor. So we don't even ask for risk factors anymore. You just assume it's MRSA.
Yeah, with an abscess.
Yeah, so I think MRSA has sort of a connotation, or people think of MRSA as like, oh, grandma had MRSA because she was hospitalized for 7 months, but it really is everywhere now. So 10 years ago, somebody said, my mom or somebody has MRSA at home, you'd be like, okay, let me write that down. But now we don't even put it in the record anymore because it's so common. So, and people are going to hear about MRSA, but there are good antibiotics against it. Yep. And we can get into some caveats about the antibiotics in a second here. So.
Yeah. So MRSA stands for methicillin-resistant Staph aureus.
Yeah.
And I just wanted to add that what that resistance means is it basically means that the antibiotic doesn't work as well against the bacteria that we're targeting with the antibiotic. So that's why we're saying that bacteria is resistant to that medicine. Yeah. And that's why I'm going to just do a little side step here. Often you might be in the urgent care or your doctor's office, and they'll say the cause of an infection is a virus. And we say one of the reasons we don't want to treat a virus with an antibiotic is we don't want to cause resistance. Because as Alex explained, when these bacteria constantly get exposed to the same antibiotic, they can get resistant, and then the antibiotics don't work when you need them. So,
and it wasn't that we used methicillin all the time. There are a lot of like similar antibiotics to methicillin that just taste better, could be used more easily once a day, for example, or twice a day. So it's a marker for if you're resistant to methicillin, then the common antibiotics that you'll see for an ear infection, for example, can no longer be used for a skin infection. And in kids, we're unfortunately down to about 2 choices. And if your child has to take a liquid, they're gross. And if you really want to turn away friends, just give them a cocktail of clindamycin next time they come to your house. And clindamycin is one of the most foulest tasting things out there. And that's what we give kids, or Bactrim doesn't taste that great either. So that's the problem with the MRSA, is that you're now having to use antibiotics that just don't taste great. And one of the main reasons for kids to come back to the ER urgent care is because they can't take it. Yeah. And it's a real problem. And so it doesn't sound like, okay, you just give them another antibiotic, but the choices get limited. And as hard as the pharmaceutical companies have tried to make these things taste better, they just don't. You can't hide. I mean, you can put lipstick on pig, it's still a pig. It's the same thing here. I mean, you can change the taste of Clinda all you want, but it still tastes really bitter. Yeah. So
just to demystify the resistance thing, it's really kind of easy to understand if you think about it this way. Bacteria are multiplying like crazy. I mean, you can get hundreds of thousands, probably more than that, of bacteria like all multiplying very quickly. And so if you use an antibiotic and that's designed to kill that particular bacteria, there's it's easy for a few of those bacteria to have mutations as they're dividing. So their DNA changes in such a way that makes it resistant to that particular antibiotic. And those are the ones that live. Like the antibiotic can't kill those because they are resistant to it. And so then they start multiplying. And so next thing you know, your nose and our skin is filled up with those resistant bacteria. And that's how taking antibiotics sort of inappropriately can cause that to happen, right?
Yeah. So returning to abscesses, it's important. The first thing you do for any abscess is to drain it. And so if either your pediatrician or nurse practitioner or the urgent care of the ear is going to drain it. If it's large, then you usually you may need sedation to drain it. You may need something called a wick to kind of have like a little drain to kind of get some pus that's deeper. So most small abscesses get drained, and then depending on how well you drained it and how big it is, either a cream that you can use or one of the 2 bad tasting antibiotics for small kids or tablets for older kids. And then if it's deeper, then it really is more of an ER urgent care drainage, because now you need to partially sedate, or at least sometimes you need to go to surgery depending where the abscess is. And those kids may need to get IV antibiotics. So again, abscess is a big family, and really depending on what it is, how it is. And also a lot of times abscesses can lead to our prior friend, cellulitis. And if you have cellulitis and an abscess, then you're really looking at antibiotics, and usually have to act quickly because those kids get sick pretty quickly.
Yeah. They can spread fast. All right, we have been teasing Paronychia since the beginning of the show. So, Marianne, you're up. Explain what exactly is a Paronychia, and I think it'll make more sense now that we've talked about cellulitis and abscesses.
Yeah, so our good friend, the word onychia, I think we've concluded means sort of fingernail or toenail, the nail that you have growing at the tips of your fingers and toes, but usually it's in your hands. And para, I was thinking as we were talking, usually means sort of nearby or next to. So and we were trying to come up with a good way to explain it. So a paronychia is an infection located at the sort of the edge of a fingernail, either the nail bed at the bottom where the cuticle is, or on the side, maybe on the little corner there. And again, it's sort of like a spectrum. It starts out almost like a cellulitis, but it's got this name because it's right there next to the fingernail. And it can be red and swollen and tender and painful, and maybe even cause a little bit of fever. But it starts out kind of small. It gets pretty impressive, and it's very uncomfortable. And it is a potentially serious infection. So that's usually why they end up coming into the doctor. And if you don't treat it, it can get worse and then lead to maybe like a felon, which is not someone who's a criminal, but something that is like an abscess, our friend, the abscess. So
Yeah, deep
again,
in a finger.
yeah, your whole point of we're following this down the skin, we're following it down in the area next to the fingernails. And again, treating it. Oh, one thing I do want to mention, people whose hands are wet a lot or have lots of irritation around their edges of their nails, maybe nail biters or people who pick at their nails a lot, thumb sucking even. Ingrown nails can also can cause people to be more likely to potentially get a paronychia.
I also said this in the winter when kids get little cracks at the nails because of
Skin is so dry.
Skin is dry, and it's really painful. And then parents think it's painful because it's dry, and next thing you know, it gets infected, and you get the pair of nichias.
So then you can try to prevent that by not having those behaviors, keeping that skin moist as not too moist, but using a good moisturizer. But then they do need to be treated. Sometimes if you're lucky and you catch it really early, warm soaks or like soaking with like a betadine or some other liquid that kind of helps get rid of the bacteria and keep it clean and help that blood flow to help fight that infection. And sometimes maybe a antibiotic cream, but probably most often they'll be treated with an oral biotic as well.
Yeah. So kind of it's a little abscess next to the fingernail.
Yeah, if you see it in your office or urgent care, you drain it. It's like any other abscess. You want to get
really
if it's there.
Yeah.
If it's something drainable, you try to drain it.
Yeah, yeah, absolutely. Since we're talking about nails, another thing that's fairly common are the ingrown toenails. Tell us about those, Alex.
So ingrown toenails are when the corners of a nail grow into the soft area around the nails, so the soft tissue around the nails. Most commonly seen in toes, the big toes specifically, where the nail is going to a lot of times take a lot of the pressure from you just walking around. It can happen on any nail, but the big toes are the most common. And the causes are that people cut their nails instead of a straight line, they kind of put a curve to the nail, which I'll do for my fingers. I mean, and you tend to think of toes as the same way, but the toes are more likely to kind of grow to the sides instead of like a rounded shape. They can be extremely painful and can lead to either a paronychia or just a lot of irritation in that toe, or even a cellulitis of the toe. We had one in clinic around a month ago that ended up going to peds surgery to get that toenail removed because it was just so abscessed underneath. We put them on an oral antibiotic, sent them to the ER. So the treatment for that can be manyfold. Let's start off with trying to avoid these things. So cut your nails, especially on the feet, as a straight line instead of curving. Avoid tight shoes because that irritates that soft tissue. It opens up and then the nail can work its way in. Avoid really wet socks or wet shoes where that skin gets potentially irritated. And then also, if you have one that's, if you're prone to infections, let's say you are on a medication that makes you more prone to infections or have a history, let's say, of diabetes, you have to be very careful to avoid these things because they can spread very quickly. So that's more prevention. And once you have one, it depends on what you see. If it's an abscess, it gets drained by somebody. If it's not an abscess and it's just an early one, first soak the toe or the foot in like betadine or Epsom salts to kind of toughen up the area, but also get rid of the infection. And then try to cut that edge of the nail off. But don't be a hero. In other words, if it's really deeply in there, ask somebody to cut it for you. And we've sedated kids in urgent care just to cut off a little piece of a toe because it can be toenail. Yes. Yeah. Toe. I guess. Very important. Yeah. No. Yes, we do that too. No kidding. So it's painful. So it's hard to kind of get that the little piece out of there.
If you and I am speaking from personal experience, if you are a kid who keeps getting ingrown toenails, you can see a podiatrist and they have some fancier things that they can do too to stop those from coming back. All right, let's move from nails to hair, and head lice is something that we hear a lot about in kids. Marianne, tell us about head lice.
I'm just like trying to think of what would be the best way to start the conversation because
it's a non-bacteria. We can start off with that.
It's not a bacteria, and we have moved on from skin to nails to hair. But the reason I wanted to say it that way is I think it causes so much angst and worry and suspicion even of, where did my child get this? And yes, it's annoying and you want to get rid of it, but it's not as horrible as people think. So head lice are little bugs that love to live on the scalp or other hairy parts of the body. And the adult ones lay the eggs and they cement those to in the hair that's growing out of your scalp. And then it takes a week or so for those little eggs to hatch, and then there's little nymphs or whatever. The eggs are called nits because you hear about nits. And then those hatch, and they need another 8 or so days to grow into bigger head lice. And then they like to feed off the nice warm blood and debris in the scalp. And those are the adult lice. It's easier to see the nits because they're usually fairly white and they stay on the hair follicles, the pieces of hair. And the adults kind of move around, but they're a little not as white, and it's harder to see them usually when you're trying to look for them. But they can cause itching, probably itching, and depending on how much biting they do and how much scratching people do, you can sometimes kind of get superficial scratches and maybe a little bit of irritation that might even lead to a little bit of infection and potentially a cellulitis, but that's pretty rare. But the bottom line is that it's annoying, it itches, and we want to get rid of it. And so there's different medicines and shampoos that people can use to do that. Usually it takes 2 applications a week apart. If you don't want to use any of those, some people talk about combing through continuously every strand of hair on the scalp to get rid of the lice, but you have to do that multiple times and be very, very patient. I think one of the bigger things is the fear of catching it. They don't jump, so you don't catch it from sitting by someone. Do you have to have no nits to go back to school? No. Kids can, once they've been treated, they can go back to school and should be in school. Some kids used to miss tons of school because these nits are stuck to the hair, and kids were kept out of school a long time because of that, even though they had been treated with an effective treatment. And then the extent to which other things are contributing to it, like hats and pillowcases and bedding and stuffed animals, it's not a bad idea to launder what you can launder in hot water and a hot dryer. Things you can't launder, if you can send it to the dry cleaner or put them in a sealed plastic bag for a couple weeks, and so there's just no oxygen that gets to the lice. Adult lice can't really live more than 3 days off the body because they need a warm environment and they need food. So I'll pause there.
Yeah, I think that's where the phrase nitpicking comes from, because in the past, before antibiotics or antiparasitics were around, to make sure that you got rid of all your head lice, you had to get rid of every single nit. Was one nit can come back, become an adult, and start the whole process again. And these things can be very cemented on. So it is a long process. And for kids that have long hair or very curly hair, like thick hair, it's almost impossible to get it out of there. And it is, like you said, patience. It is a patience thing. There's actually a place here in Columbus that is called head lice removal. You pay your $200 and somebody sits there for 2 hours and gets rid of your child's nits. And it's...
Yeah.
And they've been around for like 30 years. So I guess business is good because it's, and that's where nitpicking comes from. You have to be very detailed to make sure you get every single one. So now we give medicine. So,
okay. So if you want a good business idea, take a food truck and turn it into a nitpicking mobile unit, that you can call and it'll go around the city, come to your house and take care of the head lice.
I'll skip on that one. So yes.
I don't know. It's a business opportunity. I'm telling you.
Another thing about the nits, because they are stuck to the hair. And back in the day, especially when people said you couldn't go back to school with any of those, the youngest nits they're deposited on the hair as it comes out of the scalp. So if the only nits you see are an inch or 2 down the piece of hair, those are probably empty eggs and they're not live and they're not going to cause a problem. But if you do see nits close to the scalp, then chances are you're either still infected or have just become relatively.
Sometimes in the news, I don't know, every few years you hear about super lice that are resistant to the antiparasitics that we use. But there is an argument to be made that maybe they weren't treated, effectively, or they didn't repeat it a week later, or they didn't, follow the directions. But there are some fancier things that we can do if it doesn't seem like the first things are working, which is really beyond the scope of this. But never fear, we have other tricks up our sleeves.
Yeah, like Dr. Mike's head lice truck. So,
But one other thing too, and I haven't heard of this more recently, but you used to hear literal horror stories where people used kind of home remedies or home things like kerosene or things like like that to kill the lice. And it's A, not good, but B, children were actually caught in fires because it's very flammable, and often this was near a source of heat, and they had terribly tragic outcomes. So,
and some of the products that are out there are alcohol based and are flammable. And those usually aren't our first line, but I have used them before. And I always tell parents, like, look, this is a flammable substance, no cigarette. We don't like it when you smoke cigarettes around your kids anyway. But, when you're using this particular medicine, you don't want any open flames whatsoever nearby.
And just to be clear, flammable means it catches on fire easily.
Yes. Okay, so our heads are all itchy now. And the next one we have up, I thought I'd put the itchy things together.
Moving on down.
Is scabies.
Yeah, moving on down. So, so scabies is another critter that likes to live in your body. So unlike lice that are more mobile, scabies will burrow into your skin and kind of live comfortably underneath your skin and lay their eggs underneath your skin. And scabies in adults tends to be in between the fingers, so what we call the in-between triginous finger area. So you get these little like red streaks and like almost like little burrows where these critters live. In kids, they tend to be hands, feet, toes, fingers, but they can be anywhere. And all three of us have seen infants that have scabies literally all over the body. So how do you know it's scabies, not something else? They're very itchy. You'll sometimes see like a red line where the kid was actually scratching at it, or you'll see almost like what we call a burrow. We had one in clinic the other day where we weren't sure what it was. So I was like, when we're not sure and it's like a 2-year-old, we will just treat you with the medicine for scabies. I'll get to treatment in a second, but the same comment that Mary Ann made is the fact that scabies tends to be seen in a very negative light. Oh, you must have gotten, and this is what we found out when we saw this patient, it must be that dirtball Uncle Joe's house where he got this from. That was the quote. I won't say the uncle's real name, but that's sort of like, oh, you got this because, grandpa never cleans, and it can get it anywhere. Scabies happens in every part of the city, and it doesn't mean that you have a dirty house or you didn't do the laundry. You can get it easily in school. We see it a lot with sports where kids will actually borrow a jacket from somebody else or a jersey from somebody else. We'll occasionally see it like during football season where the shoulder pads weren't cleaned properly, and those things come back to life and off it goes. Yeah. So it's very common. I think it's more common than people realize.
Yeah.
So
the really itchy rash is from the poop and the eggs that the scabies are leaving behind as they burrow. And some people may not have a really strong allergic reaction to that. And so you could have people in the house who have scabies, but really don't have much of an itchy rash. And so that's why we like to treat everybody in the house when one person has scabies, right?
Yeah, so the treatment is a cream. It's really similar to the cream that used to be used as first line for head lice, but it's a higher concentration. And you leave it on overnight, you wash it off. Just like Mary Ann mentioned with the head lice, you have to clean everything that child's body touched in hot soapy water, dry cleaning. They're harder to kill in a plastic bag. So this is something where you may have to dry clean because their eggs can actually last a little bit longer. And also the whole family should get treated because once you have scabies in the house, it's kind of hard to get rid of the scabies. Yeah. The medicine itself is inexpensive, but there's just a lot of work to get rid of the potential source of it. And then also you are itchy. And as you kill off these mites, you actually now have dead mites who may have sort of like pooped on their way out because they're like stressed out. And now you have a horrible itch. So I always warn families that the day after the cream is given, your child's going to have probably the worst day of itching from during this whole course. So commonly give an anti-itch medicine like hydroxyzine, for example, just to kind of make sure that the child is not going crazy, just scratching all over their body.
Yeah.
Because if they scratch all over their body, then they might break the skin and then get another infection.
Cellulitis. Yeah. And then you don't have to repeat, but almost all of us will repeat again in 7 days just to make sure you got good coverage of everything down there.
One thing with scabies, if you sometimes it gets misdiagnosed or a family thinks that it's that scabies isn't the first thing that they're thinking about, and you think maybe it's a contact dermatitis, which we talked about last time. And one of the treatments for that is hydrocortisone cream, which kind of settles the immune system down. But with scabies, the immune system to some degree is keeping the mite in check. And so if you use hydrocortisone cream on a scabies rash without treating the scabies, sometimes that can also make it much worse because now your immune system is not keeping them in check.
Yeah, and the nice thing is that the medicine, the cream is pretty safe, unless you get in your eyes or like in your mouth, for example. But if you do neck down, it's a fairly safe medication. It dries nicely. So it's one of those things where I'll tell parents, I'm not sure if it's scabies or not, but just in case it is, before we put you on like a high dose steroid cream, let's just make sure it's not scabies.
Yeah.
And, people hate hearing that because it's like, where did my son or daughter get the scabies? But it's really common.
Yeah.
And
the rash may, even once you treat it, it shouldn't spread anymore, but the rash may still last for quite a while because the poop and the eggs are still in the skin.
Yeah, it takes a good week to 2 weeks sometimes to completely clear the rash, but it looks better every day.
Yeah, absolutely. All right, scabies, ringworm. We're just traveling down all these things that make people shudder a little bit.
That's right.
Tell us about ringworm. Is it a worm?
Oh, you took my little punchline.
I'm sorry. I couldn't resist.
I don't know how it got the name ringworm. Maybe because typically ringworm is kind of a little circular patch on the skin with kind of a rough center and a little bit of a raised edge. So maybe this will be fun to look up. Maybe people thought that was like a little worm that had encircled this area and set up a little housekeeping. Nevertheless, ringworm is actually a fungus. So we've been talking about bacteria, we've talked about parasites, right?
Critters.
And
insects,
mites, bugs. And now we're talking about fungal infections, which can cause a whole range of infections. Some are pretty mild and some can be very serious. But today we're just talking about the superficial ones on the top of the skin. And there are lots of different places on the body where these fungus can set up. So the fancier name for ringworm, we talk about tinea corporis, which is tinea is the name of the fungus, and then corporis is the word for body. But you can also have it on your scalp. You can have athlete's foot on the feet, jock itch, and on the groin area. So basically, wherever they like to set up housekeeping. And why is it a problem? It's annoying. It's itching. It can get pretty inflamed if it spreads, especially a covered, enclosed area. So we do want to treat that. And again, depending on how serious it is, it can be a cream. And I think one of the important things about using the cream is that you have to use it long enough. It's a longer period of time. And sometimes you have to use an oral by mouth antifungal medication.
Yeah, especially if it's in the scalp.
Yeah,
definitely, yeah.
I want to add two things here. One is some sports will not let you play if you have ringworm. So, for example, if you wrestle, they will not let you play with the active ringworm. So that's a play or a wrestle. So it not only can spread, but it also can spread easily to other people. So you really want to get rid of it. And fungus doesn't grow very quickly, and things that grow quickly tend to die off quickly if you kind of give them a medicine that stops their growth. Fungus tends to be like the sloth of the critter world. And so I usually tell families, once the ringworm's done, go an additional 2 to 3 days. So you may not see anything anymore, but just knock out whatever's still there, because the antifungals work on a very slow sort of multiplying, living organism. And you may still have some remnants there your body's not reacting to anymore, but it can come back. So you really don't want that coming back. So
yeah, absolutely. And the fungus, if there's hair there, tends to get down into where the hair is growing from, like down under the skin to the hair follicle. And so that's why with the scalp, if you just treated it with a shampoo by itself, it's not as likely to go away. And you really do need a medicine by mouth for like a month.
I was going to say 4 to 6 weeks. Yeah.
And that's something where parents are usually shocked. But, if you explain why you're doing it for so long, then I think people are fine with it. But
yeah, I like the way you describe that, because it's because it grows so slowly. And I love the analogy of the sloth.
Yeah.
I'm going to use that.
You can have it on your truck. So yes.
We get rid of ringworm too.
Yes. Yeah.
Oh my goodness. Okay. Let's move on to acne. And Alex, you are up for this one. This is a really common one that a lot, especially preteens and teenagers, deal with quite a bit.
This can be a whole hour on its own.
Honestly, it could.
I'm actually going to just stick to a couple of things here.
Okay.
And so acne is essentially an overproduction of sebum, or sort of like fat / oil
Yeah.
near a hair follicle of your skin. And then you get what we call a comedone, which is a raised area. It's a whitehead if it's not open to the air and it just comes out white, or a blackhead when it has an opening, and now you get either some dirt or bacteria or oxidation of that oil, and then you have a blackhead. Acne can easily be seen on almost any part of the body, most commonly face, back, chest, occasionally on the upper arms as well, and shoulders. So when you worry about acne, I think anybody can worry about acne for just social reasons. So if you have acne on your face, that's something you're going to worry about. So there are a lot of good options out there. And again, almost like ringworm, it takes a long time to clear this. And this is more of a chronic issue, meaning it's going to hang out for a while. And it may take 7 to 10 days just to see any response. And then you may need to take the acne creams, for example, for occasionally years, depending on how bad or how prone you are to getting acne. Some acne can become an abscess, which we talked about before. So like a pus, zit with pus in it. And you tend to be leaning towards a different class of anti-acne creams for those cases. And acne could also be something called cystic, which tends to run in the family, where it's like these big boils underneath your skin. And that's usually dermatology gets involved in those, because you may need to take a medicine by mouth called Accutane. And that has to be sort of monitored by a dermatologist.
Yeah.
So acne is a huge field. So I think I did it at least some justice.
I think one thing I would add is to take it seriously, because especially significant cases of acne can cause scarring that really can last, your whole life. You can have scarring from acne from when you were a teen. And to some degree, that scarring is preventable if you treat the acne aggressively and in an appropriate way. So I wouldn't look at it as like, oh, it's just acne. We'll find some Clearasil or, other products just over the counter. But if it's getting out of control, get them to see dermatology.
And a lot of preteens and teens, it's serious. I mean, we unfortunately live in a world where there's a lot of bullying and making fun of other people. And acne is one of the most common. There was an interesting study that kids with acne had a significantly lower quality of life score compared to kids who came from the same exact background who didn't have acne. And a lot of it came down to bullying. Yeah. And it makes a difference. Yeah.
And even we may diagnose it as severe or moderate. Even what we might call mild acne can have a big impact on a child's a young teen, emerging teen, or older teen's self-esteem. And we have so much mental health issues now. We want to support kids in feeling good about themselves. Yeah. And I think the recognition that there is a whole array of treatments that are quite effective, and you can, as you described, you can kind of put several parts of treatment in play to get a control of it, and then use 1 or 2 of these to kind of keep it under control. So I think that is something I say a lot is, well, it kind of went away, so I stopped using the medicine. And actually, you probably need to keep using the medicine to keep it under control. And one other thing, some of the medicines make it a little worse before it gets better, because they kind of help drive all that inflammation and everything and get rid of it. But you have to tell kids that before they use it too, or they'll get very disappointed.
And sometimes it can dry out the skin, and then your skin feels kind of stingy. And so then you think, well, which was worse, having the acne or now having, this dry skin that hurts? But if you stick with it, a lot of times things even out.
And then sun sensitivity. So if you're a runner, for example, or you play sports in the summer, you talk to your doctor about that. Let them know, because some of these creams can be quite sun sensitive. Yeah. They sensitize you to getting a burn. You have to be really careful about that. And we've seen some bad cases this year in either clinic or urgent care. Like kids had burned faces just from acne medicine.
Yeah. And that's the other thing. I mean, there's a whole lot of different ones. So if something doesn't work or causes a problem, there's probably something else you can use. And that's why you want to go back and check with your doctor or health provider.
Yeah. I think that is so important across the board, and with so many things, and not only in pediatrics and adult medicine as well. Your doctor always says, like, if this isn't working, let me know. If you have questions, let me know. And a lot of times when something doesn't work, I hear people like, well, that doctor didn't know and it didn't work and I had to, you know what I mean? And then there's a lot of complaints and dissatisfaction. But I'm telling you, as a doctor, your doctor wants to know when things aren't working, because what they thought might work has worked for lots of other people, but it may not for you. And there are certainly going to be other options. And you just got to maintain those channels of communication with you and your doctor.
And there are steps that we go through. You treat this way, and if that doesn't work, you move to the next step. But we can't do that if you don't give us that feedback.
Yeah,
so we mean that when we say let us know.
Absolutely. All right, we are in the home stretch now. So viral exanthems. So that's a big word, I know. Mary Ann, what are viral exanthems?
Well, this is one of my favorite areas. I think these are rashes. And we've talked about bacteria, we've talked about critters and bugs, we've talked about fungus, and now we're talking about viruses. So we've moved away from things that usually require a treatment, like an antibiotic or an antifungal or an
anti-critter.
Anti-critter, right.
Yeah.
But the interesting thing to me about viruses, the rashes you get with a virus infection, now some of them are just very general, but there are a dozen or more or less that are very kind of unique to the organism, the virus that's causing them. So we can sometimes actually pinpoint which virus is causing a rash based on the things that we ask the patient and learn about the patient and see when we examine them. So the timing, when it started, and the order in which symptoms occurred. Like, did they have a fever? Did they have a fever at all? When was the fever with respect to the rash? Where did the rash start? Did it spread? And we need to know the details about where it started and how it spread, or did it all just come at once? And then did it change in appearance? So most of the time, basically the rash is still a sign that the body is fighting against whatever infection is there, and it's showing in the skin. And kind of the interesting ones, I think Alex is going to talk about chickenpox in a minute, so I won't steal that thunder, but that's a really cool rash that is disappearing, right?
Except when you have it.
Except when you have it, yeah. And one that is kind of reappearing is measles. So there are specific, I think people should pay attention to the rash associated with measles, which tends to start out on the head and neck and then move to other parts of the body. And usually kids with measles are very sick, and early on they have the 3 C's. A cough, and not just a little, but a real hacking cough. Coryza, which means a really awful runny nose, and conjunctivitis, which means redness and really red inflamed eyes. So that measles rash is very different from the chickenpox rash that Alex will talk about. And you hear about hand, foot, and mouth disease. That's a virus that's caused, it's a condition that's caused by a whole bunch of viruses. We see it usually more in the summer, and we see often little pimply-like, little pinpoint things raised on the hands and the feet and other parts of the body, and in the mouth, so hence the name hand, foot, mouth. You might have heard of Fifth's disease or slap cheek. That's what we used to call it, where for some reason that rash shows up on kids, especially younger kids' cheeks, just bright red, and maybe a little lacy rash on the inside of their arms. But they're happy as pie. They don't feel bad, but they've got this really interesting rash. And then roseola, which is a rash that may start up the upper body and move down. But it's interesting because it scares everybody, because the kids have 3 to 4 days of really high fever, and that rash doesn't show up until later. And then you're like, oh, good, this was just an uncomfortable but usually not serious viral infection. And then there's all the miscellaneous ones and others.
Yeah, I have 2 caveats here, and they both go back to the topic of, I think doctors can do a better job of warning people about viral rashes. And I'm going to pick on roseola first. So febrile seizures are, you probably had an episode on febrile seizures, where a high fever spike in younger children will give them a seizure, which is just due to the fever or fever seizure. And they'll commonly come to your office, they'll come to urgent care, ER, and you're just saying, is this from a virus? And the seizure's from the virus. And the parents are already petrified about the fact that their child sees. And they're thinking you're an idiot because you have no idea, you're not working this child up at all.
And you're saying just a virus.
Yeah, just a virus, yeah. And then the most common cause is HHV6, which causes roseola. And then 3 days later, these kids break out in a rash. Now they know you're an idiot because you didn't tell them, because you missed something. So warn them about the fact that this is part of the progression. We're in the middle of an enterovirus epidemic here in Columbus. And you named the enterovirus, we're seeing it in urgent care, ER, or primary care. Just warn the families that after the head cold symptoms and the diarrhea clears, you may get like a little pinpoint red rash. It makes the parents feel so much better because now they're thinking something else is wrong with me. People are petrified of rashes.
And fevers.
Yeah, and fevers and diarrhea. I mean, those like the 3 big ones that bring them to urgent care, and rashes scare people. So just I think we need to do a better job of just telling them, I think this is a virus and this is the rash it can't cause. And I should have like a little booklet of rashes I just show people and say, this is what you may see in a couple of days in your child.
I think I used to show people pictures of the rashes too. And I think that's kind of reassuring. It's like, see, I'm not just saying it's just a virus. And I think the other thing, especially back when we were not as careful about antibiotics, and people would get antibiotics. Oh, it's a child with a fever. We got to treat it. And the parents want to be treated. So we give an antibiotic. And then 3 days later, the fever's going down and then the rash comes out. And now they're labeled as allergic to the antibiotic.
Yeah.
And that has long-term implications for their future care too.
Yeah, I have some stats on that given to me by my good friend, Dr. Dave Stukas, who is an allergist here. He likes to say 10% of the population thinks they're allergic to penicillin, but of those people, only 10% really are. And so a lot of people get labeled allergic to antibiotics, whether penicillin or others, but their rash really was from a viral infection, not from the antibiotic that they were on. So if this is a public service announcement, if you or your child have been labeled as allergic to penicillin, you may want to see an allergist because they can easily do a test in the office to see if you really are allergic to it or not.
And that's so important because there are drugs that are related to penicillin and they're the best drug for something that you might get later in your life. And you want to use the best drug and you want to use the most focused drug. You don't want to use these alternatives that are way too much for whatever that potential illness is and cost a lot more and set you up for even more potential infections down the road. That resistance issue.
Yeah, absolutely. So I included chickenpox specifically in this discussion because this is an example of a virus that, at least in the beginning of our medical career, that we did see quite a bit. And then the vaccine came out, I think in the mid-90s. I think that's probably about when it was.
It took a decade for it to come out.
Well, and it was in Japan, as I recall, for like 10 years before we started giving it here. And I hardly ever see chickenpox anymore. So, I mean, this is really an example of where vaccines have gotten rid of a virus that potentially could kill you.
Yeah, we're seeing it more, though, because there are now people hesitant to get this vaccine. So first, an anecdote, I like my stories. So I had a 7 or 8-year-old come into urgent care and he's like, I got rooster illness. I was like, rooster illness? And he goes, I got the chicken pops. So, and ended up being scabies, actually. But these are like little fluid blisters and they look like a dewdrop on a rose petal. That's the best way to describe it. It actually looks like there's a little bit of redness and like put a piece of water in there. So these little fluid blisters, they come in crops, which means that you have one patch and then a couple of days later another patch. And then that first patch starts to crust over. Kids usually have like a runny nose with it or they feel a little sick. But chickenpox, or the virus is called varicella, can actually get into your lungs and give you a really bad, what we call pneumonitis or pneumonia infection. And I used to do infectious diseases for a living. I've seen kids actually in the ICU from really bad chickenpox. There's a reason we did this, not just to get rid of this virus, because it can actually lead to serious lung and brain problems.
Well, about 100 kids a year used to die of chickenpox, at least. And then if you get it, I'm sorry, I'm interrupting.
Oh, go ahead.
If you get it as an adult, if you escaped getting it as a kiddo, adults get very sick with chickenpox and are much more likely to have these terrible complications and to die.
And then those blisters can get infected, and you get cellulitis and abscess, all the goodies we talked about before. So, unfortunately, we're starting to see some more cases because of people just being hesitant to give a vaccine that's been out
measles,
for a while.
Like with polio.
Yeah.
So this is a plug. So it's not just a cute little illness that you sit home. It can lead to some serious infections. And then the varicella virus will hide in your nervous system and then lead to zoster or shingles when you get to be a little older. And which again is not the most pleasant thing. And if you're really old or have some kind of immune problem, it can actually be life-threatening also. So that's my chickenpox story.
Yeah, and please get your children immunized against chickenpox because it's still out there.
And if you got behind during the COVID times, catch up. Don't just wait around. Catch up.
Yeah, absolutely. All right, we are down to our final skin condition, and that is going to be hives. I don't know how we've gotten this far on skin without talking about hives, but let's do it now. So, Marianne, tell us what we need to know about urticaria or hives.
There's a lot to talk about hives, and I feel like we may have talked about that once in one of our series discussions about maybe allergic reactions or whatever. But hives show up on the skin. That's why we're talking about it today. And I was about to say that we've moved away from all the infectious diseases and things that can cause all these other things we've been talking about. But once again, you can get hives from viruses or lots of other things. So basically, hives show up as little or large. Red welts is probably the best way to describe them. So they're a little bit raised and they're red, scattered all over the body, and they itch and they itch. And did I mention that they itch? They really bother people because of the itching. And what it is the body it's the immune system, a different part of the immune system that's reacting to whatever's causing the hives by releasing histamine, which is a chemical in the body that and mast cells. I'm getting too deep in the weeds here. That cause this inflammation and swelling and itching. And basically, sometimes you never know what caused it. Clearly, if you know that you're allergic to something, like if you really are allergic to a medicine or a bee sting, if you're allergic to a bee sting, you may have a much more severe reaction. But a bug bite or a food, and usually food is a different kind of allergy too. But a viral infection, there's just so many things that can cause hives. If you go to the doctor for it, you'll be asked a lot of questions about what you might have been exposed to. And sometimes we'll nail it, and sometimes you just never know. And you can have short-term hives and long-term that may last 6 weeks. It can come and go, which can be very annoying and irritating. And if there's a specific thing that you know that caused it, you can either avoid that in the future or treat it if there's something that's treatable. And in the rest of the time, we're kind of managing the symptoms based on how uncomfortable and how widespread it is. And we have a lot of really good second-generation antihistamines now that you can take once or twice a day that can really help control that itching and all that inflammatory reaction without making you sleepy. So, and some of those are over the counter and pretty effective.
Yeah, and two caveats here. So for parents, you're always looking for not just hives, but other signs of a bad reaction. So if your child is not breathing normally, having GI symptoms such as vomiting, severe diarrhea, severe abdominal pain, that child needs to be seen like now, because that means that allergic reaction is now giving you a total body or a systemic reaction instead of just hives. And I don't want to say,
if you've been given an EpiPen in the past or an epinephrine auto-injector, and you have hives and another, like the vomiting or trouble breathing, use your device.
Yes.
Or if you're afraid to use a device, call 911 and they will probably use the device on you. And so hives can sometimes just be an annoyance, but they can be very serious, especially if another part of the body is involved. And then on the other hand, the allergist did a study and they could figure out the reason for hives around 40% of the time. And they are a lot smarter than me and probably than all three of us. And they couldn't figure out hives on like almost 2/3 of the kids that they saw. And like urgent care or clinic, I can maybe completely say this hive is due to 1 out of 10. I mean, a lot of times it's viral. We're seeing a virus now that gives hives, but you don't know. And it could have been the ice cream that you had at the local store, and could have been, I don't know. And that's the problem with hives, is that it'd be such a it just happens. Yeah. And so many causes of it.
Yeah.
And parents are frustrated, but that's the data. Like literally 1 out of 10, 1 out of 5 people, we can figure out what the hives were caused by.
All right. Well, we have covered lots of skin stuff. Before we go, I wanted to ask Alex once again about primary care pediatrics at Nationwide Children's, because you guys are a very large group that takes care of lots and lots of children around Central Ohio, right?
So we are, I think, the largest academic, which means associated with a medical center, primary care clinic system in the country for pediatrics. And I think it's now over 200,000 patients that we follow. We have about, I have to get the latest numbers. We're closing in, I think, on like over 250,000 visits per year. Maybe it's 150 unique patients and 50,000 visits a year. We're up to 15 clinics. We're opening up, actually not open, so 16 clinics, and then about a dozen school-based clinics, plus 2 mobile vans. So it's a big system. There's about 100 of us that work for this clinic system as far as medical providers, and then I'm going to say close to 1,000 nurses, social work, psychologists, counselors, registration. It's a huge team, and it's busy. And I'm very proud of the people that I work with. It really is a labor of love, because a lot of days you're really busy.
Yeah. And you do teaching too. You teach residents who are learning to become pediatricians.
So 6 of the 15 or 16 clinics now are resident clinics. So there are 5 for the pediatric residents and 1 for the internal medicine pediatric residents. So,
and a lot of the clinics are very invested in the community that they serve. So they have events around different holidays to celebrate activities for the kids, back to school events and backpacks and school supplies, veggie van, the opportunity to get fresh produce by Local Matters comes to the Hilltop Clinic weekly during the good weather. And actually, I think it's going to come year round. So there's a lot of activity carried out by the clinic teams and the primary care network to really support children and their families holistically.
But you don't have a lice removal van yet.
Not yet.
I think we'll pass on that. So,
All right.
We'll refer to your van.
Leave it to me.
Yeah.
It's not going to be mine. I'm just putting that out there. But someone, may come up with that. I mean, there's pet groomers. It's the same,
Same idea.
Yeah, exactly. All right. Well, we have definitely run out of time at this point. I want to remind everyone that we're going to have lots of links for you in the show notes over at PediaCast.org. You can find out more about primary care pediatrics at Nationwide Children's with one of those links. We also have links to What to Do When Your Child Gets Sick, the book. And remember, we have that 40% discount code over at PediaCast.org. Our Pediatrics in Plain Language survey and the playlist on SoundCloud will have links to both of those things. And then also the first part of this episode, Your Child's Skin Part 1, which was episode 518. We'll put a link to that in the show notes as well. So once again, Dr. Marianne Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital, thank you so much for stopping by today.
Oh, thank you.
It was great to be here.
Thanks.
Celebrate Health Literacy Month in October.
And wishing you a knit-free October. Yes.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks to our guests this week, Dr. Marianne Abrams and Dr. Alex Rakowsky, both with primary care pediatrics at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You'll find our entire archive of past programs there, show notes for each of the episodes, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. Also, don't forget about our sibling program, PediaCast CME. That stands for Continuing Medical Education. It's similar to this program. We do turn the science up a couple notches and offer free continuing medical education credit for those who listen. And that includes not only physicians, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast.